Welcome to Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets hit or miss comedy. I'm Matt Zires, and each week I'm joined by my residency buddies, Drs. Laura Ferris and Tim Patton, where we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll actually have some fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and all the other major podcast platforms. Just a note for everybody, there is a video component which has the key figures and tables and our beautiful faces on it. So I know most people listen in the car, and I got to tell you, I myself listen at 2x all the time. But if you want to see what we're talking about or see the articles or get the links to the articles, go to the Scholars in Medicine platform. All right, so this week we've got a great deep dive for you. This is going to be fascinating. We're going into what's a really hot topic in the world of dermatology, chronic spontaneous urticaria, and kind of the new drugs that we've got either available or about to be available. So let's just get right into it. Dr. Patton, what do you got?
All right. My deep dive was in the March 2025 issue, Diagnostics, titled Autoimmune Thyroid Diseases and Chronic Spontaneous Urticaria, the Role of Hormones, Antithyroid Antibodies, and Ultrasound by Galushan et al. This was a combined retrospective, prospective study performed at a universal hospital in Serbia. And I think if I tried to pronounce it, I would offend any Serbians who may be listening. Like Matt said, as a review of sorts, CSU is in the news. It's a hot topic. So just quick reviews. European guidelines for CSU published in 2022 recommend a CBC and a CRP and or ESR in all patients. And then they say, yes, total IgE and IG TPO antibodies for patients that are in, quote, specialist care. I don't know what that means.
Are we specialists? I don't know.
I don't know if U.S. groups have officially published recommendations since 2014. Recommended work up there: CBC, differential ESR, CRP, liver enzyme, TSH measurement. Although there was a more recent New England Journal of Medicine article, Chronic Urticaria, published 2022, that said laboratory testing in CSU isn't necessary and, quote, may be omitted. And that's what I do. I omit it. But I know practice.
Wait, I'm with you, Pat, and I generally don't order any labs on these people unless something weird is going on. Ferris, you order any labs on CSU patients?
No, totally based on review systems.
Yep.
Nothing I do standardly.
All right, Patton, go ahead.
But practice varies. I work with residents, and when we have a CSU patient, they'll say, should we just do the urticaria workup? I'm like, I don't know what that is. Yeah.
We should do the urticaria workup.
Order nothing. That. The study was conducted from 2022 to 2024. Authors looked at different thyroid testing that was done on patients diagnosed with CSU and compared these results to 50 control patients. So they did have a control comparison. Over the time period of the study, there were 43 CSU patients. Table 2 reviews the clinical characteristics of CSU patients compared to controls. More CSU patients have allergies, infections with H. pylori, candidiasis, other comorbidities.
Blah, blah, blah. Get to it. Do we need to check thyroid studies or not?
No. I mean, they're often abnormal. So figure 1, the graph that reviews the thyroid testing studies. So compared to control CSU patients, statistically significant differences in TSH, T3, antithyroglobulin, and antithyroid peroxidase antibodies. No significant difference in T4 levels. Ultrasound thyroid abnormalities like nodules, heterogeneous structure, more common in patients with CSU. And autoimmune thyroid disease, which I guess was based on ultrasound features. They didn't really go into that. It was more common in patients with CSU compared to controls. So this paper, confirms what other studies have shown. There appears to be a relationship between CSU and thyroid autoimmunity, but everything you read, it doesn't impact therapy or change anything. I think on a review of systems, if you suspect thyroid issues, it would make sense to check it. But I am not routinely ordering any of these because clearly you're going to see abnormalities. I mean, the thyroid ultrasound, that's
not a
terrible idea, right?
I mean, terrible idea. Yeah. Do you know why they have more thyroid abnormalities? Because they get thyroid ultrasounds. That's it. That's it.
All right.
Yeah.
But
So,
I
no,
could see
routinely, I'm
ordering.
not ordering these tests. I'm still going to do what I'm going to do. I am going to do a review of systems, probably poorly, because I will say I definitely totally missed Graves' disease in a patient. She had CSU, and then 2 weeks later she called me. She said, "Does Graves have anything to do with CSU?" I was like,
Maybe.
maybe.
So
And she said she went to her PCP and was having symptoms, and so maybe I did not do as good a review of systems as I should have. But yeah, routinely I'm not ordering these. I don't know about you guys.
So see, I think of TSH and T3 and T4 and the antithyroid antibodies as like so easy. And when I look at this article, like half of CSU people had abnormal results. Am I, I'm going to tell them I don't think it's going to affect your CSU, but maybe you should go see an endocrinologist and see if you should be on some thyroid medicine, and then maybe you'll just feel better in general. But I don't know.
Yeah, I have had other patients where that's all they have are the antibody, like the anti-TPO antibodies or the thyroglobulin antibodies, and endocrine doesn't. They're like their TSH is normal. We're not. This isn't anything we would manage. I mean, I think most mainstream endocrinologists.
But I'll be interested to see what Dr. Hawks, our
Yeah.
guest, is going to have to say. So maybe just a TSH. Uh, did it look at women versus men? By the way,
Oh, probably, but I didn't write that down, so I don't know. But I think most of the patients overall, a higher percentage were females, like
yeah,
really high.
yeah. That's what we expect. All right. So main takeaway to me: thyroid abnormalities were more common, but it may not mean anything.
It's weird because it's sort of in the guidelines. Like I think most people will be like, "Well, I am a specialist." The European guidelines say order the anti-IgE TPO. Like, then what are you going to do with
But you
it?
don't
And
do anything with it. It gets patients freaked out. I think there's some data that would suggest that the patients who have those autoantibodies are more likely to have refractory disease treatment.
that seems to be consistently true. Like low IG, the big one is low IgE, high anti-IG TPO. That ratio, when that ratio gets really high, those patients tend to be more refractory to both antihistamines and omalizumab. But not that you wouldn't try it at least. Maybe with these newer drugs, maybe it'll be like, hey, if this is the case, then this drug will work better. But it's so
Right.
early on in that. That's
Yeah,
hard
we
to.
just haven't had all these options. So,
Yeah.
what will be great is if there's a predictive lab that says, like, these are the people who should go on this drug, whereas these guys, if your IgE is high, you're going to do better on omalizumab. If it's low, you're going to do better on Dupixent. If we just had like more data to correlate, it would be great. But we don't have it right now.
That's kind of like what we're going to be talking about in next week's episode, where we may have a test like that with psoriasis. But let's get on to our next article. Dr. Ferris, what do you got?
So I have from the New England Journal of Medicine, remibrutinib and chronic spontaneous urticaria, Martin Metz et al. This is a nice paper. It has one of these nice graphic summaries. If you like to see what was this in one page with pictures, I love those. So we can put a link to that in there. But these are two identical multi-center, double-blind, randomized, placebo-controlled studies called Remix 1 and Remix 2 that evaluated the efficacy and safety of remibrutinib in patients with CSU who had failed treatment with second generation H1 antihistamines. So patients were randomized 2-to-1 to either get oral remibrutinib 25 milligrams twice a day or placebo. And the primary endpoint they used was the change from baseline to week 12 in the UAS7 score. What is the UAS7 score? It's the urticaria activity score during a 7-day period. So it basically it's a severity score for itch and urticaria hives during the week. So it's summing the daily scores for hives and itch into with a score of 0 to 3 over 7 days. So it's kind of like the PASI for hives, and the score ranges from 0 to 42 with higher scores indicating greater severity. Okay, so what is this drug? Remibrutinib inhibits BTK, which is Bruton's tyrosine kinase. It's a cytoplasmic kinase of the TEC kinase family. And since CSU, BTK is activated downstream of the high affinity IgE receptor in mast cells and basophils, and it is responsible for histamine release, other pro-inflammatory mediators, and it is also probably responsible for BTK plays a role in B cell activation, so driving that autoantibody production by B cells. So maybe those patients who have autoantibodies, maybe that's a little hint that BTK inhibitors might be an option for them, but that's totally non-data based. Okay, so these patients had to be symptomatic for at least 6 weeks and had to have failed their non-sedating antihistamine, and then they could be randomized. They also had to have, for severity, a UAS score of at least 16 and with an itch severity over 7 days of 6. And they also had to have a hive severity score over 7 days of 6 as well. There are about 300 patients per 300 patients in each study got remibrutinib. The average reduction in the UAS score was about 20 points in the Remi group and about 13 groups in the placebo group. So at week 12, significantly more patients, about twice as many in the remibrutinib group versus placebo, had a UAS of 6 or lower. So that's sort of a clinically significant result. And if you look at how many patients had a UAS of 0, which is no activity, it was about 28 to 31% of patients on remibrutinib versus about 6 to 10% of patients on placebo. So these were, statistically significant results. How about safety? This was actually impressively safe. So the one adverse event that is reported with this is petechiae. So moderate levels of petechiae through 3.8% in the remibrutinib arm versus 0.3% in the placebo arm, was transient, resulted in one patient did discontinue the drug because of it, but not associated platelet abnormalities or anything. So, what do I take for this? I went and I looked and I was like, how does this work relative to omalizumab, or I won't say dupilumab because I'm not going to steal your thunder, Matt, but or oral antihistamines. So, if you look at in the remibrutinib, study, on average, the UAS7 decreased by 20-ish. For omalizumab, that number is also right around 20. If you're well, how about in placebo? So what's the gap? The placebo reduction rate was actually a little lower in the omalizumab studies. It was about 6 to 8 versus 11 to 13 in the Remi studies. So technically that gap's maybe a little better in the omalizumab arm. We can talk about it when you talk about dupilumab. For oral antihistamines, we have a reduction of the score if you look across studies of 12 to 14, but we don't really have a placebo control rate. So, I think this is interesting. The safety's good. I'm hoping there'll be no lab monitoring with this. We'll see when it gets approved. I'm curious if Dr. Hawks has any insight onto that, but excited to have this as another tool. My other pearl, every time I work with residents, I'm always amazed that they don't know this, but, first line treatment for CSU is non-sedating oral antihistamines at the dose of 4 times the labeled over-the-counter dose. People, they're like, what do you mean you're going to give them 4 a day? I'm like, that is the first line treatment. I'm amazed at how often people don't know that. So if you take
I'm going to give you this.
That's
I'm going to give you the second line pearl on that is to be very clear that they have to take the not the D. So you don't want to do Allegra D or Claritin D or
great point.
Yeah. But yes, I actually usually do 4 times the labeled dose of either Claritin or Allegra in the morning, and then usually I'll do 20 milligrams of Zyrtec at night if the patient wants. right? If I'm trying to because I do think you start to get some sedation as you push the dose of the Zyrtec.
Yeah.
But yeah,
Either they're all
was
better
going
or they all sleep through their follow-ups with you. It's hard to know which one it is.
I was reading a study where, they said before going to omalizumab or cyclosporin, like, and this is controversial because it's not in the guidelines, but there was a study that said if you introduce a 4 times the recommended dose of a second antihistamine, a decent percentages of those patients didn't have to go on to other therapy. I mean, that's a massive amount of antihistamines, but I thought that was
You
an
do like
interesting
4
study.
Zyrtec a day and 4 Claritin a day?
Yeah.
Okay.
Yeah.
huh.
Worth a try.
Decent percentage didn't have to go on to anything else. I also thought the interesting thing with this paper was prior omalizumab exposure, especially as it relates to dupilumab, right? So 30% of the patients in both of the trials had prior omalizumab exposure. I don't know if they teased out the effectiveness of omalizumab exposure versus non-omalizumab exposure.
Yeah.
Yeah, I did
In
not
the,
see that in this paper and the results. It could have been hidden somewhere in a supplemental material that I missed, but it wasn't in the main body. But yeah, that is also interesting. They did not exclude those patients. Important when you think about some of the results of the dupilumab CSU,
yeah.
studies that differ with with omalizumab failure. So
Yeah.
Patton, just before I forget, send me that article about the giving people more, because I always think of it as if 4x, there's like a plateau effect where if you're at 4x and it's not working, like 5x, 6x, 10x is totally safe, but it's not going to help.
Yeah.
I didn't know there was an article out there that looked at adding 4 times the dose of a second agent.
I will send it to both of you.
Yeah. Okay. All right. Let's go
Maybe
on to my
Dr. Hawks as well.
let's go on to my study. So this was dupilumab in chronic spontaneous urticaria, Liberty CSU Cupid, 2 randomized double-blind placebo-controlled trials. So they did Cupid A, which was Xolair naive, and Cupid B, which is Xolair intolerant or inadequate responders. And then the big thing, right? The sort of elephant in the room here. So due to COVID and slow enrollment, for some reason they peaked ahead of time and looked to see how people were doing. It's called an interim analysis. And when you do an interim analysis, apparently that reduces statistical power, because what we're going to see is it number one, it looks like the Dupy just did not work so in Cupid B, who were Xolair inadequate responders, the Dupy just didn't seem to work as well. Now there's some well, maybe it was just the statistic, it was close and to being statistical significant and the whatever, but Dupy ended up having to do a third trial because the second trial didn't hit its primary endpoint. But that's one of the kind of excuses. But whenever you look at the data, it does look like it just doesn't work as well in omalizumab failures. Now, so in these studies, you had to have CSU diagnosed for longer than six months. You had to have a urticaria activity score of 16 or higher. You had to have an itch score of 8 or higher in the week before starting. People were on antihistamines and stayed on their background stable antihistamines, but they could increase their dose if they needed to for rescue. If they were already on the max dose of 4 times, they could get systemic steroids as rescue. And if you got rescued, you were considered a non-responder. In the US, the itch score was the primary outcome, and that was the FDA said it had to be. And then in the EU, the urticaria activity score was the primary outcome. That's what they said it had to be. Now, before I talk about the results, one of the things that was interesting is that the IgE levels decreased by 40 to 60% over time in both studies. But the big takeaway from this, so Dupy works, and people start to get relief, especially from their itch, pretty quickly. But and it's not a comparative trial, but just the overall numbers look very similar to remibrutinib in terms of how much people get better and how many people get better. To the point where I'm not confident saying one drug is better or worse than the other. I think that right now, as far as the data goes, I'd say they're about the same in overall efficacy, but Remy looks like it gets there a lot faster, is the takeaway. And so it kind of feels like it's going to be, okay, do you want a drug that's a new mechanism of action, like where it looks completely safe, but it's still new? Or do you want, tried and true, Dupy's been around forever, that works probably just as well, but just that maybe takes a little bit longer to get there. The other thing that was interesting, they didn't see any conjunctivitis. So it remains the case that atopic dermatitis is really the only disease that conjunctivitis seems to be an issue with Dupi. Seems to be the same in terms of arthralgias and new onset psoriasis, that kind of stuff seems to be specific to atopic derm. Those things really weren't seen in these trials, but relatively small numbers of patients, so hard to know. Either you guys have any comments on it before we bring Dr. Hawks in?
Now let's see. Let's get Jason to weigh in. I know he's an expert on this. It'll be fun to discuss the two studies with him.
So first, just for anybody who doesn't know him, you should. Dr. Jason Hawks is out there somewhere on the West Coast where all those wackos are. But I don't know if he's, I don't actually mean that, but out there on the West Coast. And I think of Dr. Hawks as the urticaria expert in the world of dermatology these days. Dr. Hawks, great to have you on the show.
Yeah, thanks for having me. No, we're not weirdos here. So we're West Coast, best coast, man.
All right. So Jason, let's just kind of get into it. So let's start where we started with Dr. Patton. When you see a new urticaria patient, what's your workup? Do you do any workup? The three of us were like, we don't really do any labs. I'm like, maybe we should do thyroid. What do you do?
Yeah, it's a good question, and I'm listening to the conversation. I think there's maybe a little cleanup we can do because I think there's some misunderstanding. It's important to make sure we're talking about the patients that truly have CSU, right? So differentiation from acute versus chronic, we're greater than 6 weeks. Those are our chronic patients. 80% of our patients have CSU, spontaneous by definition, right? No external triggers, not pressure induced, not heat induced. That's CIndU, 20% of the chronic cases where there's a clear trigger. But if you look at chronic urticaria as a group, sometimes we'll call it CU. There's a lot of data. What's that?
Let me interrupt you there,
Yeah.
because CIndU is one of those things that I'm always like, who cares? Like, other than telling you, like, don't get cold, don't scratch yourself. Like, do we manage them any differently?
Yes. Well, so that interesting point. I think the part of what we're trying to identify is that we're trying to help patients not be miserable, right? So if truly there's an exposure that they can minimize, right, then that's helpful. But to your point, you can't just be in a bubble and not get pressure. So if you have symptomatic dermatographia, like you just can't stop having pressure. But I think, like, I'll tell you to the point here. So the reason I got into urticaria was as a second-year medical student. I was diagnosed with cold urticaria. Actually saw one of the dermatologists, allergists, and actually they tried to enroll me in the omalizumab studies, but I failed the ice cube test. So even though it was clear that cold was the trigger, and to the same way, I can't avoid cold, and I've had that so more than 15 years now. But I know that sort of anticipating that trigger, that I can minimize disease. So like if I'm going skiing or working out in a cold area, like that's something that I can kind of prep for. Sometimes it's taking more antihistamine. So, but I do think having knowledge of that trigger, I think, is important. But I think
I almost don't want to know, because once I know that it's pressure urticaria or dermographism or cold urticaria, if I document that in the chart, now I can't get omalizumab, I can't get Xolair or Dupi or Remi when it comes out. I feel like it's almost bad for the patient to document it in the chart.
You could probably say there's an overlap, right? I think they've even shown that, especially with dermatographism. Right? Isn't there a fair amount of patients?
It's about 30%. And I think to your point, like we do a lot of things clinically that help us get to the therapies for our patients. And that's not going to change. We've been doing that for years in a lot of inflammatory diseases. But I think when we see these patients, what we're separating out is that it helps patients to know there's not a cause per se, like an external environmental cause. What we're really saying in CSU, and this gets back to your what do we do for workup, is that it's not coincidental that twice the number of women get chronic urticaria, right? They also tend to have a higher rate of autoimmunity. So if you look at the two very specific mechanisms in urticaria, there's IgE dependent mechanisms and IgE independent mechanisms. There's clear autoantibodies as one of the key triggers for activation of the mast cell. So even though checking thyroid and those things don't really change our management of the urticaria. What we're really saying to patients is that urticaria often precedes most of the comorbidities. So autoimmune thyroiditis is by far the most common. We see celiac disease, we see lupus, we see rheumatoid arthritis. So, we just had this in one of our trial patients that has subclinical thyroid disease, but once in the clinical trial, wouldn't have passed our review of systems. But then in the trials, like we check all the labs, has, florid thyroid disease. Right. So we pick this up sometimes. So I think what we're really saying to patients is that it's not going to change our management, but you're at risk because of the mechanism of forming autoantibodies that can hit other tissues, that you just need to be aware of that. So as things pop up, I think it was Laura that talks about the review of systems. It's good to say, like, if you're starting to develop some new things, like, keep that in the back of your mind that you have this, predisposition for autoimmunity, which strongly correlates with the urticaria, but it also correlates with other disease states. So I look at it that way. So I don't tend to check labs. The urticaria guidelines, there was a huge debate about this. We just did the International Urticaria Guidelines revision in Berlin in December. And I'll tell you, even that group was split because Derms really felt like, is it really going to change much? And I think the overall recommendation in those guidelines was that we recommend against extensive testing. And I think it's really recognizing some of the small percentage, about 1% of patients with chronic urticaria actually go on to find that there's some underlying malignancy or some other condition which can sort of drive activation of mast cells. But, we're not going to look for those little ones. So I tend to not do it.
Let's get to the money. So in somebody with a negative review of systems, you feel fine. They're not getting fevers. They're not getting joint aches. They're not, do you do so normal review of systems? Do you do any labs?
No, I don't.
Okay. Fair.
No, I just have the conversation.
Yeah.
I think we're all on the same page.
I agree.
Yeah. I think
we should have been invited to Germany. Why were we not there?
Yeah.
I don't quite understand this.
Well, Laura and I, we've been to Germany together. So
yeah, we have been to Germany together. Not to make you guys jealous, but we have.
Yeah, for psoriasis. So I think bottom line for the listeners is that we want to let those patients know that the labs are really to screen to make sure their health is otherwise good. And they just need to know that over time, there's a very high rate of autoimmune conditions that develop in these patients, not directly related to the urticaria, but in conjunction with their overall risk.
So, Jason, how do you tell people that they don't need allergy testing? Right, because that's the big food. What food? I need to see what
root cause.
What
can I avoid?
Yeah.
Yes, that is the hardest conversation.
Honestly, it's these patients when they come in, we don't see a lot of. I've had urticaria for 4 weeks or 6 weeks. Like, we get those occasionally, but most of the time it's like I've been to a bunch of primary care doctors and the ER and. I've seen an allergist or a couple of allergists or, someone's cycled me through a bunch of these different treatments. And so most of the patients we see are already in that well into the chronic phase. And the fact is, if they could have controlled their disease with cutting out milk or bread or, they would have already done that. So I usually kind of start to say, look, if this were a simple fix, you probably would have already done it because you've cycled through, you've changed all your bed sheets and you've fumigated your house and, you've done all this stuff already. And I think that's a good indication where we say that's why the definition of this disease is chronic spontaneous urticaria, or what we used to say, you guys all remember the chronic idiopathic urticaria, right? We're trying to highlight the fact that
I like idiopathic better.
I did too. And I sort of bring that up to say we're really differentiating it from the inducible, right? So this is internal. It's your innate immune response, not that different from other inflammatory conditions. Nobody with rheumatoid arthritis sits around and says, hey, what food caused my rheumatoid arthritis? And they just start to get in the mindset of thinking about the immune system as driving their disease. And then you move away from that. So I say, what do you want the allergist to check? Because we know this is your immune system. Like, it's overactive. It's otherwise healthy. So I just try to break through that barrier conceptually. And then I try to quickly focus to, do you want to go through all that testing? And maybe if we can find an allergist, because that's part of the problem sometimes, or do you want to just focus on getting better? Because I can help you there. And usually that kind of breaks that conversation.
All right, I'm going to tell you guys how I do it. Here's what I say to them when they bring up food. I say, so do you know anybody who has like peanut allergy or shellfish allergy? Oh yeah, the kid at my kid's school and blah blah blah. Well, so when they eat the peanut, it's like 2 days later, then they get some hives, right? Like, no, well, exactly. If there was a food you were allergic to, your mouth would swell up the second that you ate it. The fact that if there are no foods that your mouth is getting itchy whenever you eat it, we know it's not food allergy. And that has been the most effective, like, okay. And then really emphasizing that we know it's autoimmune, right?
Yeah, and actually, to your point, Matt, I say something kind of similar. I say, have you ever had episodes of hives repeatedly where you didn't eat milk or bread or whatever they think it is? And that's a nice screening, because the definition of spontaneous disease, they should be breaking out in the absence of what they think is their trigger. And so it's very easy for someone to say, like, I think it's this, cut it out for a week. The transient nature of urticaria, you're either going to get it or not get it. And most of the time, if someone could say, well, I don't always get it with milk or bread or whatever they think it is, boom, that's it. There you go. So you took away your disease. This is a disease that cycles through, very quickly, in hours in most patients, that it doesn't take you very long to tease that out. So that helps them conceptually kind of break that connection.
All right, so let's get into the drugs. So, right, we're going to kind of skip talking about Xolair because the use in derm is just, there are some derms who use it. They don't need to learn anything new about it if they're already using it. The derms who don't use it aren't going to start using it. So let's kind of skip Xolair. How do you differentiate them, right? So let's assume Remy is about to get approved later this year, and let's say that all happens. How do you differentiate them?
Yeah, I mean, two very different approaches, right? So we're talking about an injection, well known to derm, tried and true safety profile. We're then comparing that to an oral medication, so 25 milligrams twice daily, very fast onset of action. One's a little easier to wrap your head around in terms of how it works. The other is a little more indirect. So if we think about remibrutinib, right, BTK inhibitor, this is the intracellular pathway within mast cells. So, analogous to, say, the JAK-STAT pathway, where it's intracellular, it's a kinase pathway, but it's going to be I think of it as a convergent pathway. So the IgE dependent and the IgE independent mechanisms go through BTK. So theoretically, by blocking BTK, we should be able to also capture those patients who don't just have IgE mediated disease. So I think of it in that way, where you're going to capture the type 1 autoimmunity, which is the IgE dependent, versus the type 2B autoimmunity, which is non-IgE dependent. So mechanism like IgG.
I want to talk about that just a tiny bit more.
Yeah.
So the IgE dependent mechanisms for CSU, is that like you have IgE against an autoantibody? So basically you're allergic to yourself? Is that how there's an IgE dependent mechanism?
Yeah, so this is actually pretty cool immunology. So you have the high affinity IgE receptor. It binds to the Fc portion of the antibody. So you've got the two variable ends sticking out. Well, they can cross-link each other with an autoantigen. So if you take double-stranded DNA or TPO, for example, it can bind to two variable ends and then cross-link. That activates the mast cell.
So that really is equivalent to being allergic to something, allergic to yourself.
Yeah, so that's the idea of like checking TPO or double-stranded DNA or some other internal intrinsic antigen. So that mechanism is where directly the IgE antibodies cross-link activate the mast cell. Then you set off the cascade, degranulation, and then you got all those proteins driving disease. So that's type 1. Type 2B is going to be like IgG antibodies, which can then bind to those same IgE antibodies and act as the allergen and cross-link it. So now it's not allergic to yourself in terms of TPO or some other antigen. It's an autoantibody binding to those IgEs, activating it, and then setting off the cascade. But also, those IgG antibodies can bind directly to the high affinity IgE receptor and directly activate mast cells. So this makes sense when you say, well, now you've got this convergent mechanism. It can be activated. BTK gets activated through both of those. So if you have a patient theoretically who's not responding to anti-IgE with omalizumab, and because they have IgG-mediated disease, BTK should still work. So it's kind of that idea is it should broaden the ability to capture patients. And this is why IgE sort of losing favor, right? It's because why do we check it all the time? Because you had a therapy that blocked IgE, but you have all these other non-IgE mechanisms. And that's why remibrutinib, very fast. So within 2 weeks, about a third of patients had well-controlled disease. So, I mean, this is the big differentiator there is, but you got a pill taking twice a day. You've got a kinase, which is going to set off the trauma of all the people afraid of the JAK inhibitors, right? It's another kinase. And not everybody wants to take a pill twice a day. But the fact is, these patients it works in urticaria. It works in patients who also have angioedema. It works for type 1 and type 2B disease. And so I think we do push the limits on skin clearance overall. And you guys talked about the safety. I mean, petechiae, 4%, that should be the least of the worries of the dermatologists who see petechiae all the time. None of these patients had thrombocytopenia or blood abnormalities. So I think what the real selling point of Remi is very fast oral option, don't have to have an injection, get it on quickly and have the medication shut down disease. Totally different. Yeah, go ahead.
Well, it's going to be interesting. I think of JAKs. So first, again, for anybody, BTK, totally different from JAK inhibitors, no cardioembolic risk, none, doesn't have any of the warnings, not immunosuppressive, nothing. But I think of JAKs as, and there's data to back this up, if somebody's itch isn't getting better in the first couple weeks, the JAK is probably not going to work at that dose. And it'll be interesting to see with Remi, is this going to be a drug where like, okay, if you're not seeing anything in the first 2 weeks, this is probably not the drug for you. Let's move on to something else. Right. Which I haven't seen any data that tells us that yet. But
yeah, well, I think we do see an early signal by 2 weeks. Like I said, I mentioned that third of patients who kind of have well-controlled disease, but their primary endpoint was 12 weeks. And there are patients who do even better beyond 12 weeks. So while you have a fast onset, and we have those patients with, atopic dermatitis, for example, on the JAKs where they start to see improvement, but they don't really peak out until a little bit later. So I think of this as having really its full benefit by 12 weeks. 8 to 12 weeks is kind of the full benefit. But some of those patients who have maybe more severe disease may take a little bit longer. So I think the big sell, again, fast onset, oral, works for hives and angioedema, and probably based on what we see in the early trials, probably no major adverse events and really no infections, which is going to be a big change from the non-selective BTK inhibitors that we saw in the cancer space. And I think that's in contrast to dupilumab, right? So it's an injection.
Wait. Before we go into Dupy, so Patton, you're in the lecture we're given here in a few weeks, you're talking about BTK inhibitors kind of beyond urticaria.
Right.
What I haven't really looked into it. What other stuff does Remi work in?
I think they're looking at it. I don't know if it works necessarily. I think there's a clinical trial in HS. There's other BTK inhibitors. There was one that, didn't look great for pemphigus. I think the company that was studying it decided they're not going to continue that indication. But there was another Japanese study, completely different BTK inhibitor. Hadn't even heard of it before. Some of their data starts to look pretty good. I think you have it for there's a BTK study for Sjogren's. They're really just kind of expanding out. This is a really dumb way to look at it. The JAKs, and you think of, look what they've done to T cells. BTK is more like neutrophils, mast cells, the diseases where those cells are predominant. We may see BTK inhibitors really come forward as, just like we've seen with the JAKs. That's my spiel.
So Jason, have you worked with Novartis? Like, are you working with Novartis on the other stuff that they're doing with Remi too?
Yeah, we have their HS study that's coming. We also have their head-to-head, which is remibrutinib versus dupilumab for urticaria. We have other urticaria studies, but I think of it as BTK is predominantly expressed in mast cells, B cells, a little bit of basophils, and actually some platelets, right? So that might explain part of
So
the
why
petechiae.
the heck does it work in HS? Is
Yeah,
it
so the
because
thought, it's interesting because the thought has been there's been some immunology showing that there's a B cell signal in HS. I don't think of HS as a autoantibody based disease, but there are papers out there published showing B cells may play a role. And so you're seeing some of the bispecifics now blocking IL-17 and BAFF, which is a B cell activating factor. So I think it's a messier disease, so it may contribute there. But I kind of look at these BTK as being different from the other BTK inhibitors because the way it works, it's nuanced, but it binds to an inactive form of BTK. And that inactive form, the Y551 that sticks out when it binds, it makes it unique, and it's a covalent bond. So you're binding to this unique part of BTK. You're not binding to other kinase inhibitors, and it prevents upstream activation of it. So that's what keeps it more selective. So we're seeing totally different profile than the non-selective, non-covalent binding BTK inhibitor. So I think that's where Novartis got this one right.
Pat and Ferris, any other Remy comments with their questions for Dr. Hawks before we go on to talk a little bit about Dupy?
If you have to, talk about Dupy and then I'll ask my question.
All right, and Hawks, I'm gonna give you my. Why the hell so I believe that Dupy works in CSU because it generally shifts your immune system away from a type 2 Th2 phenomenon. That's my best guess. But like I've been on ad boards with you where we're like, we don't know why it works. Like could be this, there's a lot of reasons it could work. But what's your guess? What do you think, if I had to pin you down, of all the different hypothesized ways, what do you think?
Yeah, I mean, there's very few drugs where like we know exactly why this works. In fact, companies do this all the time. They're like, when it's not clear that this is the exact mechanism by which it gets this disease better. Like we see this all the time in diseases like generalized pustular psoriasis. Like, well, this exact mechanism may not be known in the way it works. And so I think we have to be careful because we're doing human clinical trials. We're not doing mouse models and in vitro studies. But I think we have to look back at that clinical data, and we can make some pretty good.
Stop dancing around, Hawks.
So,
what is it? Why?
Here's
I know you don't
here's
know.
what I think.
What's your guess?
I think what we're really looking at in urticaria, we clearly have activation of mast cells. We clearly have a role of autoantibodies, and we have type 2 cytokines, which are elevated in lesional and non-lesional skin. So when we look at urticaria, we kind of see those pieces. So when you block IL-4, for example, IL-4 is the main driver of type 2 differentiation. The mast cell is a type 2 cell. So by blocking type 2, it's the main signal for type 2 differentiation. In the same way that blocking IL-23 is the main signal for type 3 inflammation. So we're blocking the production of differentiated type 2 cells, which includes the mast cell. I think that's number one. Two, by blocking IL-4 and 13, we're blocking isotype class switching, which is the production of IgE, which accounts for the type 1 immunity, as well as other antibodies. So if autoantibodies play a role, you're going to reduce that with dupilumab, and that's one of the other mechanisms. Interestingly, mast cells that are activated, once they're activated, they degranulate. Those are the preformed proteins, histamine, tryptase, etc. But then after that, they start to upregulate production of cytokines, including type 2 cytokines. So they directly make type 2 cytokines. And I think the last thing is that all these other cells that come with type 2 inflammation, we've got basophils, we've got eosinophils. They can also make some of these other signals, right? They also have BTK signaling. And I think the direct component of these cytokines on itch, I think prurigo nodularis is a good example where it's not just IL-31, IL-4 and 13 can activate the nerves. So we do get some neural sensitization. That makes sense from itch, right? It's not just IL-31. We see itch drop in our atopic dermatitis patients on dupilumab. So I think these are some of those core points that I think you can make sense of why it might work. Again, it's a little more indirect, but our immune system isn't linear. They're always it works, a lot of different layers.
Hey, I always say the people you should listen to least are basic scientists. They have no idea what they're talking about. It's
I'm a
not
translational scientist, so I'm not a basic scientist.
well, exactly, because the basic scientists just say this cytokine's elevated, so it's in this. We don't know if we don't know if anything is an innocent bystander or pathogenic until we have an antibody that blocks it. That's when
Right.
we find out if it matters or not.
Well, what'll be really interesting, I think, to tease this out, when we have other drugs that work by different mechanisms, we start to learn about the other ones, right? So the fact in AD where we can block 4 and 13, then you just block 13, then you just block 4. Well, 4 didn't work in AD. 13 does, but 13 doesn't work in things like food allergies and asthma. So we're learning about the role of 4 there. And I think in the same way, I think it's unlikely that IL-13s would work in urticaria because I think IL-4 is tied more to that type 2 pathway. And so that will help us, right? If you see a drug that works in urticaria, like dupilumab, but not IL-13 inhibitors, then that helps tease out some of the mechanisms. So we can still learn by going backward. But here's the clinical data with urticaria for dupilumab is that they measured the itch ISS7 was their primary endpoint. Different 24 weeks, secondary endpoint UAS7, but the UAS7 is still hives plus itch. And the fact is they reduced itch and hives very similarly to some of these other urticaria mechanisms, right? So I think that's a pretty good metric because the HSS7, that's hives. It's either 0, no hives, 1 is less than 20 hives, 2 is 20 to 50, and 3 is greater than 50, right? So they had a 10-point reduction in that score, which is just the formation of hives, which is what we're relying on clinically. So that worked. So I think that's the proof in the pudding first. And then we work backwards, like, okay, well, now how do we explain this? But that's how the translational scientists work. Like, it helps patients, then let's work backwards to try to figure out how it works. And I think that's where we're at with Dupy right now.
So Ferris, you started that. Go ahead, Ferris.
Yeah. So here's my question. All this antibody testing that we're like, it doesn't really matter because it's not going to drive what we do. But, now when we're going to have like 3 options, do you think there's going to be some predictive value? Like the people who have elevated IgE are going to do better on a BTK inhibitor. The people who have, IgG driving this are going to do better on Dupy. Like, do you think that maybe we'll be able to use this to help us pick the right drug for each patient?
No, I don't.
I want the answer to
Good
be
question.
Yeah.
It was a great question,
Great
Ferris.
question,
I was buying
Laura,
in.
but so anyway, here's why I'm saying this. So your question is very important because what we don't have in dermatology, even in diseases like psoriasis or atopic dermatitis, is the ability to predict a patient's response to a therapy. It's still try and fail. It's like, lottery system in some way. We know there's a higher likelihood that you'll respond to some of the newer therapies, for example, but I think we need that biomarker. What's interesting in urticaria, both Novartis and Regeneron Sanofi have data showing that your response is independent of IgE levels.
Mm-hmm.
Now, Dupy used a cutoff of less than 100 and greater than 100. And then Novartis looked at it at lower levels. We think that probably the cutoff of around 40 to 45 is a little more clinically relevant for IgE levels. But actually, internal data within Regeneron Sanofi show that it actually doesn't matter. So IgE levels as a biomarker of predicting response to either of those medications were not the case. So I think it's actually challenging this idea of the diagnostic value or predictive value. It might predict response to omalizumab, but to Matt's point, who cares if derm isn't using it? What's the point in checking a lab test?
I think there's not good data that elevated IgE predicts response to omalizumab, but maybe you guys can remind me. I haven't looked at those papers in a while. I don't think it does matter.
There have been, it's mixed, but there are studies showing that people with low IgE levels don't respond as well to high IgE, which makes sense in terms of the mechanism of action. But ironically, there's also patients with really high levels of IgE who also don't respond. So it just shows you there's other immune circuits that can help kind of drive disease. So it's not the end all be all. We need good biomarkers, but I think here we're going to basically be choosing therapies that either one we're comfortable with, it may be comorbidity. So I think on the Dupi side, they take a little longer than Remi. They probably peak out between week 12 and week 24. Week 24, their readouts, it takes a little longer for this to kick in. It's a more indirect mechanism. But the safety of this medication, the familiarity in derm, this is already taking off. If you start to look at the data right now for the use of it in urticaria, it's actually tracking very close with what we're seeing with what AD's launch was with dupilumab. Wow. So I think the uptake in derm is already, really doing well. I think derms just needed to get access to something. And I think these patients that come in with asthma or mild atopic dermatitis or other type 2 comorbidities, which we know can be common, I think this is going to be an option where people already have that success. Your point, Matt, that the BTK is new and it's different, that's going to give some people some reservations. We joke about who writes dupilumab. That's even the people who don't write biologics, right? So there's a very high comfort level that I think is going to offset maybe their choice for remibrutinib. And I think having multiple options is always better for these patients. But I don't think we have good predictors of why should I use this versus this, because they both work pretty well when you give them time to act.
Okay. All right. Well, Pat and Ferris, unless you guys have anything else you want to ask Dr. Hawks, where I think we're ready to kick it over. Dr. Patton, you better have some trivia. Dr. Hawks, I don't think we warned you. At the end of every episode, we have Dr. Patton puts together some trivia related to the topic for us. The rule is you got to let him finish the question. Once he finishes the question, if you got an answer, you just shout it out.
All right. Well, the category is hives, so let's go. The musical band, The Hives, hails from what European continent?
Europe.
Yeah,
European country.
I'm going to go with Europe on that one, Tim. Next question.
Let's narrow it down. Part B. Which country?
The Hives.
Sweden.
England?
Belgium.
It's Sweden.
Yes.
Ferris, did you know that, or was that a guess?
I did.
Wow.
We actually brought up the Hives before, but they're one of my favorite groups. And if you ever have a chance to go see the Hives live, absolutely do it. One of the most entertaining live shows. So I actually, there was a previous trivia question.
Go in the door, just in case.
Yeah. All right. The term urticaria derives from the genus of plant known as Urtica, which is more commonly referred to as what?
Nettle.
Stinging nettle.
Yeah, I'm going to tie. Matt you guys both sort of started at the same time. The answer is the same. Nettle, stinging nettle. That's it. Have you guys ever touched a nettle plant or came into contact with one?
I don't think
Not that
so.
I know. Not that I know of.
I have. And the other plant I was thinking of is the euphorbia, which are the spurge plants, the spurge dermatitis that, so poinsettia is one of those plants that it can cause a blistering reaction much faster than the poison ivy, for example.
Yeah, I knelt on a nettle plant and it is like instant and it is horribly irritating. It's amazing how quickly and irritating that plant can be.
Hence the name, stinging
impressive.
nettle. Yeah. All right, number 3.
What is the English translation of the German verb masten, which Paul Ehrlich used when naming Mastzellen mast cells in 1878?
I have no idea.
Nope. Got me.
Purple.
No, that's a good, I like that guess. It means to fatten or stuff. He looked at these mast cells. He saw all these granules. He thought there were these cells that were like feeding on something. And that's what gave them that appearance under the microscope. So it means to fatten would be like the best translation.
I have always, the number of times in my life when I'm talking to a patient, so it's like a little water balloon, but it's not filled with water. It's histamine. It's called a mast cell. I don't know why it's called a mast cell, but that's what it's called. Now, so the German word for fat.
To fatten, like you would with an animal, to stuff it up before you kill it and eat it.
All right, fair.
Yeah.
All right. Well, Dr. Hux, thank you for joining us today. It's been a ball having you on. I want to thank all of our listeners for joining us this week. If you got questions, comments, or ideas for topics you'd like us to cover on the show, shoot us an email at questions@dermsondrugs.com. Hope you learned a few things. Hope you laughed once or twice. And mostly, we're hoping you're planning to join us next week. And until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.